All right, this module is going to go through the hepatic, biliary, and pancreatic systems. Your role as a physical therapist is to understand the basics of what these systems do, how they function normally, and what happens when they fail. So understanding some of the basic signs and symptoms of what it looks like to have liver disease or a problem with your gallbladder can assist you in assessing a patient who might have multiple comorbidities or who might be demonstrating some sort of sign or symptom that could be confused as a musculoskeletal or neuromuscular symptom when it's really something more systemic. So making sure that we're alert to red flags and aware of how these systems should be functioning. It's important to note throughout this module that particularly in the hepatic, biliary, and pancreatic systems, there can be significant destruction of these organs before signs and symptoms even start to become obvious. So while we might recognize a sign or symptom, we may not be saving a patient from destruction of this organ, but we might be some of the first healthcare providers to notice a problem. So first we're just going to talk about the anatomical location of the liver. The liver is mostly protected by the rib cage, and it's a right-sided organ, although it does cross into the left side of our thoracic region. Like I said, it's mostly protected by the rib cage, and it extends all the way down to about the 10th rib. If a patient has an enlarged liver, it may actually extend down below that region. It's also sitting just on top of the respiratory diaphragm. So when a patient's breathing, the liver actually moves a little bit too. And that's one way that we're going to be able to try and palpate the liver by kind of like hooking our fingers around the edge of the rib cage when a patient inhales. It's not very easy to palpate a liver or to know exactly what you're feeling if it's not something you do regularly. But it is something you might be able to get to. If you think about sort of the basic location of the liver, if you're looking from the back, it extends somewhere from about T10 to L1. And again, the liver extends all the way across midline and into the left side of the chest with the smaller left lobe. We'll talk about this a little bit more in class, but the liver is about the size of a football, so stop and think about that. It's pretty big and weighs about 3 pounds. So when I say the liver might be involved in a few critical roles, I'm probably being sarcastic. The liver has an extensive number of roles in many different systems within the body. So one important role is filtering the blood from our gastrointestinal system. We might think of this as the way we metabolize alcohol, but as that blood flows from our portal vein into the liver, we're basically processing everything that comes through our gastrointestinal system. So this is how we metabolize alcohol, but also how we metabolize medications and process nutrients. So the good and the bad go through the liver. So all of these things that we metabolize include protein, carbohydrates, fat, and even hormones. We're able to regulate the amount in our blood based on metabolism in the liver. When the liver metabolizes protein, an interesting thing that it creates is ammonia, and ammonia can be really toxic, but the liver converts it to urea, and that urea then heads to the kidneys through the blood flow and is excreted as urine. So multiple different systems are connected here. Other things that the liver produces are bile, and this helps with fat breakdown and absorption. That bile heads to the small intestine, and that's where fat breakdown and absorption occurs. And also with the help of vitamin K, the liver produces coagulation factors, so it plays a role in blood clotting. It will also break down old and damaged blood cells. Other things that the liver produces are energy from the metabolism of fat, carbohydrates, and protein. In terms of storage, the liver is helping to regulate the levels of different nutrients and substances in our blood. So, for instance, if our blood sugar gets too high, then the liver can pull some of that blood sugar out and store it as glycogen. Then if our blood sugar gets too low, the liver will break down the glycogen and release it back as sugar to increase our blood glucose levels. It does the same thing for vitamins and minerals, for instance iron, where if we get too low, then we can break down that stored nutrient and release it into our blood flow so that we have it when we need it. So it's easy to imagine that if the liver has such a multitude of functions, that when there's a disease process involving the liver, it can affect multiple systems. We're going to go through each of these systems and talk about how liver pathology can impact each of them. With the presence of liver disease, we can get unusual feelings of fullness or loss of appetite because we might be struggling with the ability to digest fat. The liver is normally going to produce bile, excrete bile, into the small intestine, and that will help with the digestion of fat. So if that's not happening, the individual could have an upset stomach, feel nauseous, or vomit. We also can see a lack of normal processing of bilirubin, which is a waste product that is created after we break down old red blood cells. Normally, that bilirubin should be excreted in our bowels in feces, and that would actually help create that dark color of our stool. So when there isn't bilirubin being processed, it will build up in the bloodstream and ultimately be excreted as urine. So instead of making the stool dark, it makes the urine dark. So we get this coal-colored urine and very light-colored stools. So when liver disease impacts the integumentary system, we see the symptoms of jaundice. And you may have heard about jaundice in terms of a baby who's born without a fully functioning liver, and you see some elevated bilirubin levels and more yellowing of their skin. In an adult, this can happen as well. And what we see are maybe a slight yellowing of the eyes and the skin as well. Usually the eyes are first. Then again, the stool and urine changes that we talked about with the gastrointestinal system might become present. So stools become much lighter and urine becomes much darker. Other impacts we might see on the integumentary system are small spider angiomas, and these are basically just superficial capillaries that start to appear on the skin, and once they occur, they don't go away. So that's one indication. We also see reddening of the palms and possibly even the soles of the feet, and increased bruising. So if you remember the coagulation factors of the liver, it would make sense that if there's some dysfunction in the liver and that coagulation factor formation, our patients may show bruising more easily. Pruritus is one symptom, and this is just a medical term for itching of the skin. So for no particular reason, they will start to feel more itchy. And then there's a lot of different nail changes that you might see. White nails of Terry are one, but we're going to go through these when we go through nail bed assessment, and you can watch for signs and symptoms of liver disease via nail bed assessment as well. When we have the presence of liver disease, there are some potential associated musculoskeletal symptoms and conditions. These are not all well understood, but we know that myopathies can occur and that this might have something to do with the decrease in ammonia metabolism in the liver that causes weakness and fatigue in muscles. With the use of statins, one of the side effects we watch for is rhabdomyolysis, and this can cause muscle breakdown as a side effect and pain that doesn't fit or make sense with normal mechanical signs or symptoms. When these individuals go through lab work, we'll see elevated creatine kinase levels, and that's a muscle enzyme that suggests that there's some breakdown. Hepatic osteodystrophy would be the presence of osteomalacia or softening of the bones or osteoporosis. It's thought that that can be the result of cholestasis or a blocking of the bile duct or the flow of bile through the liver. And again, it's not entirely understood, but it's thought that this could be related to the fact that presence of bile acids in the blood might interfere with vitamin D absorption. Other symptoms or conditions we might see with liver disease are osteoarthropathy or some sort of nonspecific pain and swelling in our ankles and wrist joints. These could be symptoms confused with rheumatoid arthritis. We also could see headache symptoms more present in individuals who have hepatitis A, which we'll talk about more in this section. Now, we talked about having muscle pain or discomfort from hepatic conditions, but if we're talking specifically about the liver referring pain and where we might feel that, the autonomic innervation of the liver is about T5 to T11. So if you sort of look at where that might refer in terms of surface pain, we'll see some aspects of pain at the inferior angle of the scapula, as well as the right shoulder. And the right shoulder is probably referring pain because of the connection that the liver has with the respiratory diaphragm. And we know that that can refer ipsilaterally up to the shoulder. So one of the main impacts that liver disease can have on the neurological system is with elevated serum ammonia levels. And if you remember back to the function of the liver, when the liver is metabolizing protein, one of the byproducts is ammonia. Ammonia can be very toxic to the body, but it's converted in the liver to urea and then excreted as urine and isn't a problem. But in cases of liver disease, this serum ammonia levels can be elevated, and basically that works its way to the brain and disrupts neurotransmission in a way that causes neurological signs and symptoms and even cognitive signs and symptoms. So asteriscus is one symptom sort of novel to liver disease, and that's the inability to basically hold the arm out straight with the shoulder flexed and the elbow extended while still extending the wrist. If you put the patient into that position, you can trigger what's called liver flap or asteriscus. And if you click on the link here, I think there's a YouTube video where you can sort of see this in action. Not the most common thing to see, but in a more advanced case, you might see this liver flap. Another concern with elevated serum ammonia levels is hepatic encephalopathy, and this basically manifests with progressively increasing confusion and cognitive decline, and also motor decline, so ataxia and difficulty with motor control. If you test the reflexes of these individuals, they may demonstrate hyperreflexia. A very specific neuromusculoskeletal condition that we treat a lot that may manifest itself with liver disease is bilateral carpal tunnel syndrome. And this isn't carpal tunnel syndrome due to ergonomic changes or gripping things too tightly, but this is actually associated with liver disease. And the main indicator that this might be a systemic problem and not actually something that we should be treating is that it would be bilateral. So an individual with hepatic disease, you may see bilateral carpal tunnel syndrome. And typically in our musculoskeletal patients, we won't see this condition bilaterally. Usually there's enough difference in terms of what someone's doing with their right and left hand and how much the right or left is going to tolerate those activities that we see a primarily unilateral presentation of carpal tunnel syndrome. So if you see it bilateral, that doesn't necessarily mean liver disease. It also doesn't mean it's not something you can treat, but be more alert to that and assess that person more carefully and look for signs and symptoms of liver pathology before you make the decision that this is primarily a musculoskeletal problem. Another symptom of hepatic disease is a symptom called ascites. This can happen when there's some sort of blocked blood flow to the liver and is most common in patients who have cirrhosis. You might see lower extremity edema accumulate as well, but primarily what you'll see is an abdominal cavity that slowly enlarges with this acidic fluid that's made up of albumin, electrolytes, and water. This can be drained, but it will accumulate again as long as there is liver disease or this blocked blood flow. As we noted earlier in the function of the liver, the hormonal metabolism and control, particularly with sex hormones, occurs in the liver. And in this image you see gynecomastia, and this is when a male will develop more breast tissue because of hormone imbalances with hepatic disease. Hepatitis is a prime cause of hepatic disease, so I want you to be familiar with all the types in your text. Your text has a nice table of these, or at least be familiar with A, B, C, D, and E. A and E are more related to food and water types of contamination and contact with feces, and B, C, and D are more related to bloodborne pathogens. In the healthcare field, that might be us becoming infected because of exposure to bloodborne pathogens, and in our patients this could be because of surgical procedures, but also lifestyle choices such as having unprotected sex or using injection drugs illegally. You've probably heard of cirrhosis as it relates to liver disease. It's most typically caused by alcohol abuse, but can also be caused by hepatitis and fatty liver disease. But basically what happens in cirrhosis are that liver cells are destroyed, and when they are destroyed, they're replaced by these fibrous bands, and the fibrous bands don't function as liver tissue, so then the liver function is decreased, and you start to see signs and symptoms of cirrhosis. If we talk about liver cancer, the concern is that primarily we see before any signs or symptoms 80 to 90% of the liver has already been consumed by cancer before we are able to really see these signs and symptoms outwardly. Some of the signs and symptoms are those that we've been discussing throughout this module, so seeing jaundice, weight loss, complaints of muscle weakness, feeling full, having mid-back pain below the scapula, and just early satiety or sort of feeling full early. If liver cancer is caused by a metastatic lesion, that's likely because the liver is processing everything from the body. So the blood from the pancreas and the GI system is all filtering through the liver, so it's easy to have metastases in the liver because it's so associated with the rest of the body. If it's primary liver cancer, the list here is are possible sources. So again, alcohol abuse, things we've been talking about, infections, nutrient deficiencies, the consumption of toxic, ingestion of toxins, or specific drug use that could be contributing to the onset of liver cancer. The primary implications for physical therapists when working with patients who have hepatic disease are to be alert to the signs and symptoms and to be aware of how the disease may manifest so that we don't get confused by signs and symptoms that are too close to things that we might treat differently. Further, if we are knowingly treating someone with hepatic disease, we want to make sure that we're being cautious in terms of not overexerting them or allowing them to overexert themselves. With exertion, there's decreased blood flow to the liver, and that's already problematic in this population. So we do actually have to be more careful with these individuals than with our general patient population, and be careful to just watch their fatigue levels. So thus far we've talked about hepatic symptoms or symptoms associated specifically with the liver. And now we're moving on to the disease and signs and symptoms of gallbladder dysfunction or biliary dysfunction. In terms of just basic location, there's some pictures in your text as well, but I thought this one sort of showed the gallbladder nicely. It tucks right up underneath the right lobe of the liver, so you can see this sort of pear-shaped object up underneath the edge of the giant liver there. It sits basically at the base of the 9th right costal cartilage and is not something that we're going to be palpating specifically. So what does the gallbladder do? Well, it basically stores and distributes bile. It stores bile, and when the duodenum has food present, it will signal the gallbladder through a hormone called cholecystokinin. And when that hormone is released, the gallbladder knows to contract and basically just push some bile into the duodenum. The duodenum needs that bile so that it can help digest fats. So the bile aids in making the contents of that duodenum more alkaline and also helping in fat digestion. So if you've ever had a family member or friend who has had gallbladder issues, you know that they tend to get really sick feeling if they consume a high-fat meal. And that hopefully makes sense a bit here. The impact of the gallbladder on the gastrointestinal system is very similar to that of the hepatic system. So our patients might report that they just don't feel as well in their belly. They're full, unusually full, or feeling a little bit nauseous, or they are vomiting for some unknown reason. They may have more flatulence and more burping, and particularly again when they consume fatty food, they may feel more ill. Their pain location is usually right upper quadrant, and that can get worse also after eating. The two main conditions we may see of the integumentary system when gallbladder disease is present are jaundice and pruritus. And if you remember, jaundice comes along with multiple signs and symptoms, and pruritus is this sort of chronic itching that is unexplained. So the pain we see with individuals with biliary disease is very similar to that of those who have hepatic disease. The major overlap is right shoulder pain is possible with both because of their contact with the respiratory diaphragm, but only on the right. And then with biliary disease, we may see mid-epigastrium pain. So something that might be confused as heartburn, or something more centrally, or a bit more into the right upper quadrant of the chest. Thoracic pain, pain around the medial border of the scapular, infrascapular region is also possible, and even some spasm of the abdominals. Further signs and symptoms with biliary conditions that might be a bit more common than with hepatic are seeing constitutional symptoms, and this is having fatigue, fever, and chills. So you've all heard of gallstones. The pathological name for gallstones is cholelithiasis, and this basically occurs when stones from the gallbladder create a blockage somewhere. If it's blocking the cystic duct, then we call it biliary colic, and if it's blocking the common bile duct, we call it cholangitis. Being alert to some of the risk factors for gallstones can help you identify patients who may be manifesting some different signs and symptoms in the clinic. So be alert to the fact that women, this is more common in women, in those that are overweight, have a high cholesterol diet, but also in those who are rapidly losing weight. So if someone's dieting extensively, be alert to that as well. So in terms of signs and symptoms of biliary disease, it's interesting to note that if your patient has or reports pain right after eating, it may be more likely symptoms of gallbladder disease. And if their pain is a little bit delayed, like 1 to 3 hours, it's more likely gallstones. And if you sort of think of it in terms of the path is blocked further down with gallstones. We don't need to be able to differentiate between the two, but if we ask about eating and the patient starts to describe symptoms associated with eating, we already probably know this is not someone that we're going to be able to help with those symptoms, but we may be able to decipher a little bit more what might be going on. It might give us some confidence in our suspicions. Other things to pay attention to are that these patients may demonstrate constitutional signs and symptoms, so chills, fever, nausea, and vomiting. They may also have pain with breathing. So remembering that this gallbladder is closely associated with the respiratory diaphragm and that they may have some pain because of movement with breathing. And just some reminders in terms of how to distinguish these signs and symptoms from those that might be musculoskeletal. Remember that these systemic signs and symptoms are more likely to come on gradually and not have any sort of apparent cause. Though that may occur with musculoskeletal symptoms as well, these symptoms will be very consistent, probably constant or related to eating or drinking, which musculoskeletal signs and symptoms won't be associated with, but they'll be very consistent. And then in contrast, when we're dealing with our patients who have musculoskeletal symptoms, often they'll have an identifiable cause, or at least half the time we hope, but usually they have some kind of aggravator or alleviator that's more mechanical. And then when we start to inspect the neurological and musculoskeletal systems on exam, we'll start to see some things that could explain their pain. And finally, we're going to talk about the pancreas. So anatomically, it's located behind the stomach. It's actually anterior to L1, 2, and 3, and it's a structure about 6 inches long. Our pancreas has exocrine and endocrine functions. So the exocrine functions are very compatible with what's going on with the gallbladder, and that's secreting digestive enzymes into the duodenum and helping to digest carbohydrates and protein and fat. So whereas the gallbladder is probably more involved in fat metabolism, the pancreas functions with all three. It also helps to make that duodenum more alkaline when there's food present. And in terms of an endocrine function, the pancreas is involved in secreting glucagon and insulin and helping with the metabolism of carbohydrates. Chronic pancreatitis can be a very painful condition. We talked about it a little bit in 718 with our case of a patient who was alcoholic, and that's probably one of the most common conditions where we see chronic pancreatitis. It's probably most common in patients who are abusing alcohol. Symptoms that they might experience are, again, epigastric pain, or sort of central chest pain that's quite severe, and worsening pain if they're eating or drinking. They may actually demonstrate signs and symptoms of diabetes because of the endocrine functions of the pancreas, or they may have back pain, pain in the thoracic or thoracolumbar region. So you can see some of the other signs and symptoms listed here, and maybe interesting to note that they may feel more comfortable if they sort of curl up in a more fetal position. So while that may seem mechanical, there are other signs and symptoms should cue you in that this is more systemic. Pancreatic cancer is a terrible diagnosis and does not have a good prognosis. But it's still important that we're alert to the signs and symptoms and potentially get a patient earlier medical care if it's possible. I'm going to use my grandmother as an example here. She was diagnosed with pancreatic cancer several years ago now, but had some of the classic signs and symptoms and risk factors. So she was actually probably 6 months before being diagnosed, had adult onset diabetes. And we learned after she was diagnosed with pancreatic cancer that that's actually what was causing the diabetes. She was not necessarily high in areas of other risk factors, but she was 80 years old when she was diagnosed, so that increased age was a risk factor for her, and she probably didn't have the best diet or physical activity habits. In terms of symptoms, she was on vacation when she was diagnosed with pancreatic cancer, and they were trying to celebrate her 80th birthday, so she was struggling because she was nauseous and was periodically vomiting but didn't want to tell anyone because they were all celebrating her. When she went into the hospital, nobody could really figure out what was going on because she had these sort of non-specific constitutional symptoms. But one very astute nurse noticed that her eyes seemed a little bit jaundiced. So interestingly, that was the first indicator that there was something going on potentially with her pancreas, because that's one of the symptoms. So paying attention to signs and symptoms and some of these risk factors can help you sort of piece together a puzzle, or certainly to help a patient get the care that they need. So in conclusion, with hepatic, biliary, and pancreatic symptoms, be alert to some of the consistent signs and symptoms that cover these conditions. Shoulder pain that doesn't have limited range of motion or doesn't have other limitations in strength may be a flag to pay attention to. Any patient that has GI symptoms that relate at all to their pain. Similar to us not treating rashes, we don't treat gastrointestinal symptoms that come on with eating. So an important question to ask when you have a patient who has maybe epigastric or right upper quadrant pain. They may not be aware of that connection. If a patient comes in with bilateral carpal tunnel or tarsal tunnel symptoms, those are usually more unilateral when they're actual musculoskeletal cases. And again, any patient that's had a history of cancer, remembering that everything funnels through the liver, so it's a higher likelihood of metastases going to the liver. And if your patient's on statins, that might be something just to pick up on if they have unexplained pain symptoms. And in the case that I mentioned earlier, where I had a patient on statins and was having unexplained musculoskeletal pain. Once her doctor took her off the statins, the pain went away and we didn't actually have to treat her anymore. So that can make your life a little bit easier as well.